So now let's continue with our anterior pituitary gland. So actually guys, I've already done recording, and after watching my video record, wala siyang audio and it's almost 2 hours and I have to repeat this again and again. So funny. Okay, sige na lang. At least, alam ko naman to, part ulit lang. So to continue with our anterior pituitary gland, I'm just too annoyed with myself. So our anterior pituitary hormones, we have your luteinizing hormone, your follicle stimulating hormone, we have your thyroid stimulating hormone, we have your adrenocorticotropic hormone, we have your growth hormone, and your prolactin. So as what you can see, we have your LH, FSH, and TSH, which are of the same structure. They have a dimeric glycoprotein. That's why your LH, FSH, and TSH belongs to the same family. Your ACTH is a single peptide derived from your pro-opiomelanocortin. Your growth hormone and your prolactin also belongs to the same family because they have a single peptide. For your LH and FSH, it has a target gland, which is your gonad, and its feedback hormone will be your sex steroids and your inhibin. So your inhibin will inhibit the release of your FSH, while your sex steroids, because if you're able to produce estrogen or your testosterone, then it will send signal and negative feedback to inhibit your LH. Your TSH will have a target gland of your thyroid gland, and it will, by the formation of your T4 or T3, your thyroxine and thyroiodothyronine, it will send a negative feedback to inhibit the release of your TSH. Meaning, basically, these are their products, and except your inhibin, FSH, these are generally their products which will inhibit your pituitary hormone. For growth hormone, it will have several target organs. We will check later on, but it will also help in the production of your IGF-1 in your liver, but it will send a negative feedback towards your growth hormone. Your prolactin, on the other hand, has no known feedback hormone. Kasi nga, what hormone that inhibits your dopamine is your dopamine or your prolactin inhibiting factor. There are no products of your prolactin that can inhibits its own effect. I hope that's clear. I'm just too annoyed, guys. Promise. So to continue, we have 5 hormone synthesizing secreting cells. So these are the cells which is present in your pituitary glands. We have your somatotropes, lactotropes, thyrotropes, gonadotropes, and your corticotropes. 40% of these cells are your somatotropes and 20% are your corticotropes. Your somatotropes will produce growth hormone, your lactotropes will produce your prolactin, and your thyrotropes will produce your thyroid stimulating hormone. Your gonadotropes will produce your FSH and LH. Your corticotropes will produce your pro-opiomelanocortin. Remember that your corticotropes is the one that produces your POMC, but it will be the precursor of your ACTH, MSH, or your melanocyte stimulating hormone, and your beta-lipotropin and beta-endorphin. Meaning, it is not just as the ACTH is being produced, it can also produce your MSH, beta-lipotropin, and your beta-endorphin, coming from the same precursor, which is your pro-opiomelanocortin. What are the basic cells? The basic cells are your FSH, LH, ACTH, TSH, MSH. The acidophilic cells that is being produced are your growth hormone and your prolactin. So you don't have to memorize this all. You just have to remember that your acidophilic cells is your growth hormone and your prolactin. That's why, because they belong to the same family. Now this is the hormones being released, and these are the cells being produced. You have your lactotropes. Some books includes your mammosomatotrops. Your mammosomatotrops can also produce your growth hormone and your prolactin, and the rest of these cells. To continue, let's start first with our first hormone, which is your ACTH, or your adrenocorticotropic hormone. As I said, your ACTH comes from your main precursor hormone or main precursor substance, which is your pro-opiomelanocortin. Your pro-opiomelanocortin, when these are broken down into pieces, it will form your ACTH intermediate and your beta lipotropin. Your ACTH intermediate, if further degraded, will form your ACTH, while your beta lipotropin, when further degraded, it can form your gamma lipotropin and your beta endorphin. Doc, saan po yung melanocyte-stimulating hormone? Your melanocyte-stimulating hormone may comes directly from your POMC, or it may be directly from your ACTH or beta lipotropin. They can all be a precursor of your melanocyte-stimulating hormone. So remember, your pro-opiomelanocortin will be the precursor hormone for your ACTH, gamma lipotropin, and your beta endorphin. But majority of the function comes from your ACTH. That's why our focus here is more of your ACTH. But there are studies that show that your lipotropin can stimulate your melanocyte to secrete your melanin, while your beta endorphin is essential for, since it's endorphin, similar with morphine in structure, that's why it's pain reliever or analgesia. So I hope you get this one, you study well with this diagram. So your POMC, ACTH, gamma lipoprotein, and your beta endorphin. In terms pala ng disorders with your ACTH and diagnostic tests, it's easier for us to understand those disorders if we correlate that ACTH to its main function, to your adrenal gland. Diba? Your ACTH has a target gland, which is your adrenal gland. It's easier for us to understand the different disorders and the different laboratory diagnostics if you tackle already about your adrenal gland. And this will be discussed, and we will have a separate topic of your adrenal gland. Now let's proceed with your thyroid stimulating hormone, luteinizing hormone, and FSH. So I group them as one because basically they are of the same family. So as what you can see in this diagram, your TSH, FSH, LH, and including your HCG from the placenta have comprised of your two subunits. We have your alpha subunits and beta subunits. That's why they are dimeric glycoprotein. It is comprised of alpha subunit and your beta subunit. But what is unique among the four hormones here is your beta subunit. Iba-iba ang structure ng kanilang beta subunit. They have the same alpha subunit but different beta subunit. That is why when we test for pregnancy, remember, for pregnancy test, we are checking for your human chronic gonadotropin secreted by your placenta, your beta HCG, for testing for your pregnancy because it's being produced by your placenta. And what is unique with when we test for pregnancy is that what we are actually checking is the beta subunit. So we should be very specific with that. So we write beta HCG because whatever, if we are not going to be specific with our test, if we just write HCG, then since they have the same alpha subunit, you might detect the levels of your LH, FSH, or TSH, causing now a false increase of your HCG. Kasi nga, they have the same subunit, alpha subunit, and you can still detect that. That's why we have to be specific. That's why nilalagay namin for pregnancy test, beta HCG serum test, because we only wanted to detect the beta HCG of your placenta, and it is unique among the same family of the family itself. Kasi nga iba-iba ang kanilang beta subunit. Now let's proceed with your growth hormone. Your growth hormone are what we term as your somatotropin. Your somatotropin is released or stimulated by growth hormone releasing hormone, or your GHRH, which is produced by your hypothalamus. It is secreted in a pulsatile fashion every 2 hours. Meaning pulsatile fashion, it is burst-like. It is not constant, but rather it is a burst-like mechanism or secretion. It is great in puberty and steadily decline with increasing age. It has both catabolic and anabolic effects. So let's review biochemistry. How do you define catabolic metabolism? Catabolic, basically, it is a breakdown of complex substances. How about anabolic? Anabolic metabolism, it is a formation of your complex substances. Why do you have to break down? You want to break down these complex substances as your energy source. Anabolic, because of you have energy source, you want to store this in a formation of complex substances. So in short, catabolism, breakdown. Anabolism is formation. Now let's proceed with the actions of your growth hormone. So your growth hormones has a direct action and an indirect action via your insulin-like growth factor 1. So let's talk about your direct actions. Direct action, increase plasma glucose. It is diabetogenic. Increase protein deposition and lean body mass. Increase lipolysis. Increase your insulin-like growth factor 1, or what we term as your somatomedins. It has also an anti-aging effects. Now let's try to identify whether this is anabolic or catabolic. Increased plasma glucose. Is this anabolic or catabolic? This is bolic. You're right. Bolic lang narinig ko sa inyo. Bolic, because you're not sure. This is catabolic. Kasi nga, breakdown. You break those complex substances to form now your simple substance, which is your glucose. Because you need energy, you break down to form your glucose. How about increased protein deposition and lean body mass? Is this catabolic or anabolic? Yeah, it is bolic. Basically, this is anabolic, meaning you form your protein. You are forming the protein into complex substances to form your body mass, to form muscle. Muscle is comprised of your proteins. What is your lipolysis? From the name itself, lysis. This is catabolism. You are breaking down your fats to have energy source. Very good. So now let's proceed with its indirect action. Its indirect action via IGF-1. Basically, this is the function of your IGF-1. Bakit doc function yun ng IGF-1 but not the growth hormone? We will see later on how your growth hormone interacts with your IGF-1 or your somatomedins. Ganito yan. Your growth hormone will have a receptor in your liver. When your growth hormone is being released, it will attach to the receptor to the liver. And the liver will release your IGF-1. Basically, this will be the effect of your IGF-1. It will increase bone length and thickness, pubertal growth spurt. It will increase protein synthesis in muscles and or other organs, and increase lean body mass. And lastly, it will also increase your organ size. In general, it is not the growth hormones that makes the bone increases its length or thickens the length of the bone, or it is not the function of the growth hormone that increases protein synthesis, but it is your IGF-1. In short, your IGF-1 is more powerful to your growth hormone in terms of bone length and thickness and body mass formation. I hope that's clear. It is not the growth hormone that makes us grow. It is your IGF-1. But it is still the growth hormone that stimulates the liver to produce your IGF-1. That is why it is an indirect action of your growth hormone via IGF-1. I hope that's clear. Now let's proceed with the regulation of your growth hormone. So in terms of regulation of growth hormone, when is the time that you inhibit or when is the time that you stimulate your growth hormone? Let's proceed with start with your hypothalamus. I'll just draw pen. Let's just draw this one. Your hypothalamus. Remember, your hypothalamus will release your growth hormone releasing hormone. Your growth hormone releasing hormone will stimulate, that's why this is plus sign, because this is stimulation. It will stimulate your anterior pituitary to release your growth hormone. Your growth hormone now will go to the target tissues. Ano nga yung mga target tissues ng growth hormone? Dito, let's look at this one. The target tissue of your growth hormone will be your liver, your bone, and your fats. Sige, balik tayo dito. Your growth hormone will have your target tissues. Remember, it has a target tissue in your liver. And liver, on the other hand, will secrete your IGF-1 or your insulin growth factor 1. Your insulin growth factor 1 is what we term as your somatomedins. Your somatomedins, on the other hand, will cause inhibition. Remember, negative symbol can cause inhibition of your anterior pituitary to secrete your growth hormone. It will inhibit the formation of your growth hormone from your anterior pituitary. Ano pa po, Doc? Your somatomedins here on the other side will cause stimulation of your hypothalamus to secrete your somatostatin. I repeat, your somatomedins will cause stimulation or formation of your somatostatin from your hypothalamus. Doc, di ba kanina sabi mo somatostatin is inhibitory in action? Tama. When you hear the word somatostatin, its general action is to inhibit other hormones. Somatostatin will inhibit your anterior pituitary gland to secrete your growth hormone. It will inhibit the secretion of your growth hormone from your anterior pituitary. Doc, pakiulit po, Doc. Sige, ganito yan. Your somatomedins, di ba? Your somatomedins or your IGF-1 is being produced by the liver, which is stimulated by the growth hormone. Now, your somatomedins has two action. Somatomedins ha two action. One is, kanina, inhibition. Ini-inhibit niya ang anterior pituitary to produce growth hormone. Pangalawa, stimulation. Sinistimulate niya si hypothalamus to produce your somatostatin. Remember, the action of somatostatin is to inhibit your anterior pituitary to produce growth hormone. In short, your somatomedins is inhibitory in nature, will inhibit the function of your anterior pituitary to produce growth hormone. Its net effect will cause the inhibition of your anterior pituitary gland to produce growth hormone. I repeat, your somatomedins will have two effects, stimulation and inhibition. And the end effects of these two, either stimulation man yan or inhibition, ang kanyang net effect or end effect is to inhibit the formation of your growth hormone. I hope that's clear. Si somatomedins yung nagsistimulate na magpo-produce ng somatostatin from your hypothalamus. Hala, Doc, gulong-gulo na po kami, Doc. Mayroon pa tayong somatotropin, meron pa tayong somatomedin, meron pa tayong somatostatin. Ganito lang yan ha, huwag malito. Pag sinabing somatostatin, kanina sinabi ko na yan, pag sinabing somatostatin, inhibitory in nature, galing siya kang hypothalamus. Somatostatin, inhibitory in nature. Huwag nang maisip pag marinig or mabasa ang word na somatostatin, inhibition. Next, somatotropin. Ang somatotropin is other name of your growth hormone. Huwag pagbaliktarin ha. Somatostatin, somatotropin, and somatomedin. Ano ang somatomedin, Doc? Somatomedin is the one that is being produced by the liver by the action of your or stimulation of your growth hormone in the liver or your IGF-1. I repeat, somatotropin galing sa somatostatin, ako na lang magkamali, somatostatin galing sa hypothalamus, somatostatin galing sa hypothalamus, inhibitory in nature, somatotropin is the other name of growth hormone. Somatomedin is the one that is secreted by your liver, stimulated by your growth hormone. Pero remember, your somatomedins has two effects. It's either stimulatory or inhibitory. Pero ang net effect niya is to inhibit the formation of your growth hormone. Do you understand? I hope you understand me clearly, but if you are still in doubt, you have problem understanding those, you can just PM me anytime, okay? Okay, I hope that's clear. Let's proceed here with this diagram. It's actually the same lang. Tingnan natin. This is your hypothalamus. This area is your hypothalamus. Then it will secrete your growth hormone releasing hormone patungo sa pituitary. Tapos si pituitary magre-release ng growth hormone. Si growth hormone pupunta siya sa kanyang target receptor. Ito your growth hormone receptor sa liver. And si liver mag-act to produce your IGF-1. In short, si IGF-1 is the one that cause growth and development. Siya yung reason kung bakit tayo ay tumatangkad at nagkakaroon ng body mass, muscle and bone growth, anabolic effect, growth formation. That's your IGF-1. Your growth hormone will also have receptor to your fats. It can cause catabolism, lipolysis. I hope that's very simple and you understand the regulation of your growth hormone. Now let's proceed with the modifiers of growth hormone. Still the regulation, we already discussed is stimulation, what stimulates the growth hormone and what inhibits your hormone secretion. Sleep. That's why when you're still young, pinapatulog kayo ng mga magulang nyo at the afternoon because sleep can actually stimulate the formation of your growth hormone or secretion of your growth hormone. Kaya pinapatulog tayo last time and then kaya hindi kayo tumatangkad kasi hindi kayo natutulog nung hapon. Kasi nga, if you're asleep at that time, there will be secretion of your growth hormone. Next is exercise. Bakit kaya, Doc? Exercise simply because you need energy. And remember, your growth hormone can cause increase glucose. Remember, it can increase your glucose level when you have growth hormone. And in exercise, do you need glucose? Yes. Do you need energy? That's why you have to. Then exercise can stimulate your growth hormone to increase your glucose level. Physiologic stress, of course, when you're stressed, you need energy, you need glucose, and your growth hormone, and this will stimulate the formation of your growth hormone because you need a lot of glucose. Doc, how about hypoglycemia? Bakit po nagsistimulate si growth hormone to secrete hypoglycemia? Kasi nga, kailangan ka ng sugar. Hypoglycemia. Kailangan ka ng sugar ng katawan. Para ma-normalize ang sugar ng ating katawan, you need your growth hormone. Your growth hormone will be stimulated to increase your glucose level. This is in relation to the function of your growth hormone, ha? So, your hypoglycemia can cause stimulation of your growth hormone. What else? Here, glucose loading. Glucose loading, Doc, bakit po ba ini-inhibit yung glucose, yung growth hormone pag maraming glucose? Syempre, because you already have too much glucose. And hyperglycemia will inhibit now your growth hormone secretion. Remember, what if, Doc, kung may glucose loading ka, tapos nagsisecrete ka pa rin, nagsistimulate ka pa rin ng growth hormone, anong mangyayari? If you already have too much glucose and you still have growth hormone, mas lalong dadami ang sugar kasi nga growth hormone will stimulate glucose formation. So, mas lalo kang magkakaroon ng hyperglycemia. And we do not want that. So, that's why, pag marami ng sugar sa katawan, ini-inhibit na ang growth hormone. I hope that's clear, ha? That is why it is very important for us to understand what stimulate and what inhibits and what regulate these hormones for us to understand more in terms of the clinical aspect, in terms of what we are going to how we are going to manage our patient. Now let's proceed with the pathophysiology of your growth hormone. Your growth hormone deficiency, let's start with deficiency. So in children, it causes failure to grow, short stature, mild obesity, and delayed puberty. Delayed puberty. And it can be caused by lack of your anterior pituitary growth hormone. Pwedeng wala kang growth hormone na nasisikret ng anterior pituitary. Or pwedeng hypothalamic dysfunction, meaning walang GHRH, so walang mag-stimulate sa pituitary gland to release your growth hormone. Or failure to generate your IGF in the liver. Or pwede namang kulang ka sa receptor. Remember, yung growth hormone may mga specific receptor siya. May receptor sa liver, may receptor sa buto, may receptor sa fats. If walang receptor sa mga fats, even if you have a normal value of your growth hormone, then your growth hormone cannot do its action. That's why we can still have a manifestation of growth hormone deficiency. In terms of growth hormone deficiency, the most common cause of growth hormone deficiency is your achondroplasia. What is achondroplasia? Achondroplasia, it's a genetic disorder, and its primary feature or clinical feature of achondroplasia is dwarfism. Your dwarfism is not a disorder itself. It is just a secondary to the main problem. That's why here, the main problem is achondroplasia, and the manifestation here, or the primary feature, is your dwarfism. And one of the famous person who has achondroplasia is Mr. Tyrion Lannister. He has achondroplasia. It's a genetic disorder. How about growth hormone excess? For growth hormone excess, we have gigantism and acromegaly. So these are two different terms. You have growth hormone excess. Pag sinabing gigantism, the same with this man has gigantism, there is a symmetrical bone growth or that occurs before closure of your epiphysis. While your acromegaly there is asymmetrical bone growth occurs after closure of your epiphysis. So, Doc, ano bang ibig sabihin yan? Remember, in order for the bone to grow, it needs your epiphyseal plate. Your epiphyseal plate will have the receptors for your growth hormone so that it can increase its length. So what happens now when your epiphyseal plate is now closed? Therefore, your bone will not be able to grow because the epiphyseal plate responsible for growing of your bone is now closed. That's why when we differentiate gigantism and acromegaly in terms of their bone length, your gigantism will have an exaggerated bone length, while your acromegaly, they have usually a normal adult size length. Kaya nga, pag gigantism, ang kanilang grow is pa-vertical, pataas. Bakit? Acromegaly, that's why it's asymmetrical, pa-horizontal growth. Now, let's discuss about the approach to growth hormone disorder. So, we will have this case discussion. So, this is a case of a 40-year-old male who came in due to headache. So, this is the picture of our patient. So, right now, I'm just trying to give you an overview or idea of how doctors make a diagnosis out of these different disorders, because I want you to know how doctors correlate the symptoms, the diagnosis of the patient, and correlate this to the different laboratory diagnostics. Now, so this is our patient. Actually, this is my patient when I had my rotation in SPMC. So this is a 40-year-old male who came in due to headache. And this patient manifested with a coarse facial features. So the patient has very thickened facial bones, thickened lower jaw. The patient has prognatism, lower jaw. And one important factor talaga napansin ko sa patient ko is the very bad odor. And actually, with these symptoms, we are going to generate our primary impression. So when we diagnose our patient, before making any request for laboratory request, before doing CT scan, radiologic test, we have to make a primary impression. We have to check the history of the patient. Then, with this history of the patient, we will now check for the physical examination of our patient. So for example, this patient has, of course, facial features, very distinct body odor, had thickened lower jaw, and this is a very typical picture of a patient with acromegaly. So doc, is that already your diagnosis? Of course not. That's just our initial impression. That's not still our final diagnosis. So our final impression, our initial impression for this patient is most probably patient has growth hormone excess. Most probably acromegaly based on the physical examination and history of the patient. So that's how we make our diagnosis. Now the question is, what would be the laboratory test that we are going to request? Check natin. So in order for us to approach different growth hormone disorders, this will be our laboratory test. Number 1, growth hormone assay. Number 2, insulin growth factor 1 assay. Number 3, you can have insulin tolerance test. And lastly, we have your oral glucose tolerance test. Doc, is growth hormone assay already enough for us to diagnose the disorder? No. Growth hormone assay must be correlated with the other tests, because remember, growth hormone can be secreted in a pulsatile manner. We could have a low value or we could have a normal value even if the patient has acromegaly. Secondly, IGF-1 assay, is that already confirmatory, doc? No, IGF-1 assay is not a confirmatory, but rather could be used as a screening, because remember, your IGF-1 can be secreted by your liver, and any problem in the liver may have also effects on your IGF-1 level. It could become low or it could become high. That's why we are not sure if whether IGF-1 is really confirmatory, because any liver problem could also affect the IGF-1. So that's why it will not be a confirmatory test, but it could be useful as your screening test. Number 3, insulin tolerance test. What is insulin tolerance test? Meaning, you give insulin. What is the effect of your insulin? Your insulin will cause increase or decrease of your growth hormone. Your insulin will stimulate the formation of your growth hormone. Why? Remember, when you have insulin nagpapababa ng glucose level. If you insert insulin, will it stimulate your growth hormone or inhibit? It will. Tama, it will stimulate your growth hormone. You will increase the value of your growth hormone. Now, for oral glucose tolerance test, will it inhibit or stimulate your growth hormone level? Oral glucose tolerance test, meaning you will give glucose. Remember, paparamihin natin ang sugar sa ating katawan. Will your growth hormone stimulated or inhibited? Growth hormone stimulated or inhibited? Tama, your growth hormone must be inhibited because you have already too much glucose in the body, therefore it will inhibit your growth hormone. Question: among the two tests, insulin tolerance test and oral glucose tolerance test, which is more valuable or more important in terms sa ating case kanina, in terms sa ating patient who has acromegaly, in terms to our patient who has growth hormone excess? Is it insulin tolerance test or your oral glucose tolerance test? Insulin tolerance test ba or oral glucose tolerance test? Sige nga, isipin natin. Insulin tolerance test, meaning paparamihin mo ang growth hormone. Eh kung patient natin acromegaly, meaning marami na ang kanyang growth hormone, kailangan pa ba nating paparamihin? Of course not. It is not useful. Kasi nga, your insulin tolerance test is used to secrete more growth hormone. It will stimulate more hormone to be secreted. That is why your insulin tolerance test will not be beneficial to our patient who has growth hormone excess. How about oral glucose tolerance test po, Doc? Yeah, glucose tolerance test, meaning you give glucose, and this glucose will inhibit now your growth hormone. So, Doc, ano po mangyayari dyan, Doc? Patient natin with growth hormone excess, acromegaly, patient who have growth hormone excess. If we give glucose tolerance test, the normal effect must be, there must be suppression of your growth hormone. Dapat masosuppress yung growth hormone. However, when this oral glucose tolerance test is cannot inhibit your growth hormone, then there's a problem. Now, this will confirm us with a problem that there could be a endogenous source of growth hormone. There might be something that produces your growth hormone, because the normal response kanina should be dapat decrease mo yung growth hormone. Kaya lang bakit di nasusuppress yung glucose tolerance test? And that's gonna be another investigation. So if we are going to check on our patient, growth hormone, acromegaly, may acromegaly siya. Pinag-growth hormone assay natin siya, Doc. Normal lang po ang result niya kasi nga growth hormone assay is not very useful thing. IGF-1 assay po, Doc, normal po, Doc, kasi nga basically your IGF-1 could have a low or normal value. Could not also be a good test, but it could be a screening test. Doc, insulin tolerance test, no, we do not do insulin test. Doc, glucose tolerance test po, Doc, positive, meaning hindi niya po nasusuppress yung glucose, meaning there's still growth hormone value. So try to investigate now. Now we will make an impression that there might be a source of your growth hormone. It might not be that the pituitary is producing a lot of growth hormone because of this source, and that source could be patient might have a pituitary adenoma. Patient with adenoma could secrete a lot of growth hormone, and this growth hormone cannot be inhibited by glucose tolerance test. Is this already our final diagnosis, Doc? Is that already the test that we are going to conduct? No. We have to do CT scan. We can do MRI to check whether our patient has this pituitary adenoma. Remember, guys, that our patient manifested with headache. And headache could be a very good clinical feature that our patient might have pituitary adenoma. If this adenoma grows or becomes bigger, then it can compress the parenchyma of the brain, causing now headache. This is actually a real case of my patient. My patient, sobrang sakit ng ulo. It was a chronic onset, dahan-dahan, hindi siya abruptly na sumasakit ang ulo niya. It was just abrupt, and my patient also had a visual changes. Medyo nanglalabo ang mata niya. Remember the anatomy of your pituitary? Dito yung, tingnan natin, yung pituitary. Remember, nandito yung optic chiasm. Just below the optic chiasm is within your pituitary. And when your pituitary mass grow, it can now compress your optic chiasm. Remember, your optic chiasm, it's a convergence of your right and left optic nerve sa mata. So, pag na-compress yung sa mata mo, now the patient now can manifest with blurry vision. I hope that's clear. So, in short, acromegaly is not a final diagnosis. We have to investigate. What causes the excess of your growth hormone. So the final diagnosis of my patient was growth hormone excess, acromegaly, secondary to pituitary adenoma. So my patient underwent a surgery, and what the patient did is ang ang surgery na ginawa sa kanya is, and I was able to assist also that surgery, yung transphenoidal endoscopy. So may pinapasok kami na endoscope, and then through the scope doon namin kinukuha yung adenoma. So